Okay, we're going to go ahead and start now. We are done with the endocrine chapter. The endocrine exam is open online for those of you that want it online. If you intend to take it on ground, let me know, and I will have a hard copy available with the tutor, Jennifer, and you can schedule a time with her to take the exam there. Yes, ma'am.
Since I'm taking mine in person, do you know like when I might have my feedback?
As soon as I get it from her.
Okay.
So it's a good question. Okay. Okay, so today we're going to start on how do we work the lockdown browser? That's a good question. Let's see, works the same way it did in AP1, which means it doesn't work very often or very well. There is a video and set of instructions in the content section of the table of contents, that was redundant, on how to get the browser to work. I don't even know, and I won't repeat this, but I don't even know if I turned the browser on for that test. If I didn't, then you're fine. If it doesn't work, if you can't get it to work, let me know, and I'll see what I can do at my end. So, okay. So now reproduction. Okay. The human reproductive system is designed to produce sex cells, the gametes, the sperm cells, and the ova, the eggs. So the male produces the sperm cells, the female produces the egg cells. The males and females both release the steroid-based sex hormones, testosterone in males, androgens that are released by the adrenal cortex are really testosterone. And then in the female system, the female releases both estrogen and progesterone. Progesterone after the egg is ovulated because progesterone keeps the lining of the uterus intact. And so those are the primary roles in here, to produce eggs and sperm and to secrete the sex hormones. It's the sex hormones at puberty that trigger the development of the secondary sex characteristics. You know, body growth, enlargement of the reproductive organs, facial hair, body hair, things like that, production of the sperm in males, and the development of a mature egg in the female and the release of that egg. We also have a series of glands and ducts and genitalia, external genitalia, that are driven by the development, by the release of these sex hormones. Okay, so starting out with the male system. The male system is simpler than the female system. That's why I start with it. The male system, you've seen some of this already in lab. We have the testes, the epididymis, the penis, and the various ducts and glands here that will produce the semen and carry semen and sperm together. Now, sperm is produced inside the testes in the scrotum. It travels through the ductus deferens from the testes up to an area behind the urinary bladder, where it combines with the vas deferens and picks up about 60% of its semen. Sperm cells need semen to swim in. The first part of ejaculation is simply muscular, pushing the live sperm cells up the vas deferens up to the seminal vesicles. That's where it picks up the semen that it's going to need to swim once it enters the vagina and the uterus. Seminal vesicles produce about 60% of the semen. The semen is alkaline. It is full of fructose for energy. It contains antibodies to help protect the sperm cells, and it is a liquid medium. Seminal vesicles produce about 60%. The prostate gland produces about 30%, and the bulbourethral gland does between 5 and 10%. And so we can see here are the testes down here inside the scrotum. The epididymis surrounds the testes. That is the vas deferens going up here, combining with the seminal vesicle behind the bladder, and then the semen and the sperm moves through the ejaculatory duct through the prostate gland to the urethra. And this tiny little gland right here in the back is the bulbourethral gland. That is the first semen that's released. It is released prior to ejaculation. It helps to cleanse the urethra and cleanse the tip of the penis so that there's, to help destroy bacteria. Okay. The testes produce the sperm inside the seminiferous tubules. And the seminiferous tubules produce sperm. They lead the sperm cells to the epididymis to mature, because the immature sperm that gets produced in the seminiferous tubules is incapable of fertilization. So it has to spend about three weeks developing, and that takes place inside the epididymis. The epididymis is a storage facility that sits up on top of and around the individual testes, one on each side. And then the vas deferens, during ejaculation, the vas deferens takes sperm cells from the epididymis up to the ejaculatory duct. And about 400 million sperm cells are released during each ejaculation. Ejaculation is driven by the sympathetic nervous system. It's a reflexive action. It triggers rapid smooth muscle contractions that propel the sperm and semen out of the, sperm out of the testes and the semen out of the seminal vesicles and through the urethra into the vagina. So here are the ducts that we encounter. Seminal vesicles are on the posterior surface of the urinary bladder. There's one on each side because there's a vas deferens, a ductus deferens on each side, because there are two testes, two epididymi, two vas deferens, and two seminal vesicles. And they all combine together to go into what's known as the ejaculatory duct, which you can see right there. This gray outline structure is the prostate, and the ejaculatory duct comes through the prostate and combines with the urethra. The bulbourethral gland is all the way back here. Now, okay. Scrotum and the testes. The scrotum is a temperature regulator for the testes, because sperm cells can't function at 98.6. 37 degrees C. They have to be 3 or 4 degrees cooler because of the enzymes found on the head of the sperm. So the reason that sperm production takes place inside the scrotum is because the scrotum is cooler than the abdominal cavity by just a few degrees. And that's all it takes, because these enzymes are very temperature sensitive. So we see the scrotum. Inside the scrotum, you have a series of muscles called the cremaster and the dartos muscles they are going to be the temperature regulators because the cremaster will pull the scrotum up when temperatures drop and allow the testes to descend when it gets warm. So the cremaster helps to regulate the temperature inside the testes by drawing them close to the body of the male on a hot day, on a cold day, and allowing them to descend lower on a hot day so that they can, you know, be a little bit cooler. They're trying to regulate the temperature for us. Now, so the cremaster muscles surround the testes proper. Now, internal of the muscles, we see what we call the spermatic cord, which consists of the blood vessels and the lymph vessels and the ductus deferens, the vas deferens that leads away from the epididymis. You see the epididymis sitting on top of each testes there. The spermatic cord ascends through the inguinal canal in the abdominal wall. That's how it moves up into the body through the, you know, it goes up into this opening called the inguinal canal and passes through the abdominal wall so it can reach the seminal vesicle. That that inguinal canal does become a weak spot for stress and strain. Okay, so the scrotum, a sac of skin, keeps the body temperature, keeps the temperature inside the scrotum about 3 degrees Celsius cooler. The dartos muscle allows the skin of the testes to wrinkle or to relax, depending on temperature. The cremaster muscle allows the testes to be drawn up or drop back down. So these are the temperature regulators. So inside the testes, you have 2 layers. You have tissue. You have what is known as the tunica. Tunica means coat. So the tunica vaginalis and the tunica albuginea. The inner layer is the albuginea. It divides up the testes into 250 different and distinct lobules. And each lobule contains 4 seminiferous tubules. So you have about 1,000 seminiferous tubules in each testes. This is where the sperm production takes place, in the testes, in the seminiferous tubules. Now, the layers of the seminiferous tubules determine the rate of sperm production. These are epithelial cells there are epithelial cells that line the inside of the seminiferous tubules. They are called spermatogenic cells. What we see here is something known as spermatogenesis. Spermatogenesis creation of sperm. Spermatogenesis. So these are spermatogenic cells. We call them spermatogonia. Spermatogonia. Okay, now that's A at the end, by the way. So they will form the sperm cells. Now, unlike females, where the ovary contains all the eggs, generally assumed that all the eggs the female is ever going to have in her lifetime, males continue to produce sperm cells from puberty till the day they die. Surrounding these spermatogenic cells, you're going to have support cells, and these are called sustenanocytes. So I guess it was a bad day in naming day because that's not a great term, but sustenanocytes. Okay, so here's what a close-up of the testes look like. You can see the epididymis is on the left-hand side. And that's where the immature sperm all go to mature. It takes about 3 weeks in there. You can see the spermatic cord coming off the top. You can see the vas deferens coming off the epididymis. You can see the blood vessels and nerves leading up through the cord. And you can see the individual lobules inside the testes. And you can see the seminiferous tubules. There's usually about 4 of them in each lobule, and there's about 250 lobules. You have an outer covering and an inner covering in here. Okay. So we go, sperm production takes place inside the spermatogonia, leading to the middle of the seminiferous tubule. Once the immature sperm cells are produced in the seminiferous tubules, they are transported to the epididymis. And sperm cells, when they are mature, are stored in the tail of the epididymis prior to ejaculation. Surrounding the seminiferous tubules are what we call the interstitial endocrine cells. They're going to produce testosterone. And they're going to secrete that into the interstitial fluid around all the cells. In fact, there's a, here we go. The interstitial, these cells here, so, this is a seminiferous tubule that you see right here in the center. And the sperm cells are going to form inside these layers. Sperm cell production starts on the inside edge of the tubule and moves towards the lumen, towards the middle, and the immature sperms are collected here in the lumen. These areas here where we see the interstitial cells, those are the interstitial cells of Leydig. This is where testosterone gets produced. Now these cells tucked in around the spermatogonia are called the sustenocytes, and they are the support cells for them. So this is a much better illustration showing this. These are the interstitial cells here. And over here, for example, this is the spermatogonia along the inside edge. Sperm production occurs from here, moving towards the lumen. These are all immature sperm cells here in the lumen, which will eventually get conveyed to the epididymis. And in the meantime, these interstitial cells are busy secreting testosterone, which then is absorbed, surrounding all these other cells. So, okay. Yeah. The testes are supplied by lots and lots of blood. The testicular arteries and veins supply blood to the testes, and the testicular veins take it away. These vessels work not only to supply nutrients and oxygen and take away waste products, but to also remove excess heat. As the venous supply leaves the testes, they're carrying a great deal of heat away. As the arterial blood comes down to the sperm cells, the arterial blood's coming down, and the venous blood is going out. And so the venous blood will draw heat from the arterial blood as they pass side by side. One's going down, one's going up, and the arterial blood gives up a lot of its heat to the venous blood going back, so that the blood that gets to the sperm cells and gets to the testes is not as hot as it was inside the abdominal cavity. Now, here we see the penis in the middle of the 2 testes. Again, we see the spermatic cord. We can see the arteries and veins tucked inside here. We see the cremaster muscle, and we see the dartos there. The dartos is in this layer here. But this is the inguinal canal right here. Excuse me. The inguinal canal is the opening that allows the epididymis and the arteries and veins and everything in the cord to pass through the abdominal wall. It's where the testes descended through early on. Now, it's a weak spot. It's a weak spot in the abdominal wall that can be ruptured, can be torn with extreme, if the male increases the inner abdominal pressure sufficiently, excuse me. Okay, maybe I'll stop coughing now. If pressure goes up in the inner abdominal cavity, it can weaken or even tear the opening into the inguinal canal. And we can have some severe consequences here. This rupture, this hernia, can, if untreated, can allow the small intestine or even the large intestine to protrude through the opening in the abdominal wall. Okay. Excuse me. Okay, so I said this already about I wonder what I did. Okay. Here we see the lobules. Here we see the seminiferous tubules. We see the epididymis. Here is the tail of the epididymis. This is where the ductus deferens connects. So mature sperm that are ready to be released come out through the ductus deferens here. Sperm cells are probably in the testes for about 3 weeks. Okay. Problems. Testicular cancer. Not unusual. Doesn't happen very often. It is if you have a male between 15 and 35, that's usually the most common cancer for that age. What are the risk factors? Well, a male that had mumps, mumps mumps is a bacterial infection that inflames the parotid glands, but if it also manages to spread to the testicles, it will cause the testes to become inflamed. And so the condition is orchitis. If a patient had orchitis early in life, then they're at a higher risk factor for testicular cancer. The most common risk factor is cryptorchidism, where the testes didn't descend properly. And so that is, that's probably the #1 risk factor that we see here. What happens is that you'll get a cancer growing in the testes. It doesn't hurt. It feels like a lump, and it has a very, very high success rate, 90% or greater, simply by removing the testes on the side that's affected. It doesn't have the issues of spreading like breast cancer does. It's not, at least not as significant, because many males will have a lump on one side, have it removed, and it won't have any issues with the other side. So that's not to say they can't get it on the other side too, but it generally is confined to one side. So radiation works very well. Chemotherapy works very well. So we have lots of options with a very high success rate. Now, problems. This is a hernia. This is a hernia that is caused by tearing of the inguinal canal. What we see here, this very large mass right up here, slightly to the right side of the penis, is the abdomen, is the small intestine that has penetrated through the wall through the opening in the inguinal canal and is now underneath the skin and is pushing against the skin, and it has become pinched off. It is trapped inside this, this tear. And since it's trapped, what's happening is that it is the tissue is starting to die. So we call it becomes gangrenous. We have gangrene as the tissue is breaking down internally. So here we have this bulge in the lower abdomen because the inguinal canal tore. So it didn't tear to the outside. It tore in the canal enlarged because the canal's opening is very small to allow the spermatic cord to pass up through here. But it tore, and now the small intestine has pushed into that opening and gotten itself stuck there. It's not going to come back. And when it's stuck there, it gets constricted by the opening and starts shutting down its blood supply. Once it gets to that point, it still takes surgical intervention to fix it. Now we have a situation where the small intestine, the portion that's pushed through, is essentially dying because its blood supply is cut off. So notice also that the glands of the penis, the prepuce, the foreskin has been removed. So this is a circumcised male in here. If it wasn't, then this skin that we see there at that ring where the glands is, would that ring would not be visible because that's all that's left of removing the foreskin. The foreskin, you'll see it on another one in the next slide or two, comes down and extends all the way to the tip. Here we see another strangulated hernia. This, you'd swear it's penetrating to the outside of the body, but it's not. That is significantly inflamed and gangrenous tissue underneath the surface of the skin, again, because of tearing the abdominal wall at the inguinal canal and pushing through. Now, the small intestine has pushed itself through and is, again, underneath the surface of the skin, but it has also gotten itself trapped there. This requires, this isn't going to go away on its own, and it's not something that your patient wakes up with one morning and says, hey, how'd that happen? This has been going on for a long time. Your patient usually ends up presenting, I got this problem here, can you fix it? At that point, because how do you let something, well, that's a problem you'll encounter. How do you let something get like that? How did our patient with the goiter the size of a football allow it to get to the size of a football? Remember the picture from, again, how do you let it get like that? Okay, now this is a non-circumcised penis. You can see that the foreskin here extends all the way to the tip. It covers over the tip. This is the one issue about an uncircumcised penis, is that to keep the area around the urethral opening clean, that skin has to be pulled back because normally it covers over it. Doesn't block it, it just comes up and around it. The circumcision removes that whole foreskin, and you get that ring that you saw earlier. Now this is edema that can occur in the scrotum. Something's going on here that allowed fluid to collect inside the testes. We don't know what it is, but I will tell you that this is a good picture of edema. Note the fingerprints in the scrotum. The scrotum is so filled with fluid. When a person has significant edema, swelling of their tissue, they have this dimple effect. If you press down on the tissue, you'll leave a dimple with your finger and it won't go away. Normally when you press on your skin and it dimples and it goes away as soon as you take your finger away. Here, it didn't. You can see the fingerprints where the testes were examined right before the pictures were taken. So a person with significant edema, swelling in their legs, swelling in their arms, swelling in the testes, the dimple isn't going to go away easily because there's too much fluid in there. Okay. Now, as I said earlier, we know where the sperm come from. The sperm comes from the seminiferous tubules. They're produced by the spermatogonia, and during an ejaculation, they are propelled up to the seminal vesicles where they combine with semen. Now, semen is important to provide a fluid medium for the sperm cells to swim in, because that's the only way they have it moving. The semen contains fructose, it's alkaline, contains the fructose there provides energy for the mitochondria. And you generally produce about 5 mils of semen during an ejaculation, and somewhere in the neighborhood of about 150 million sperm per mil of semen. Typically, an ejaculation will have about 400 million sperm. A healthy male that's fertile will produce about 400 million sperm cells and about 4 or 5 mils of semen. If you get below 20 million sperm, you're essentially considered infertile because you're not producing, there won't be enough survivors to fertilize the egg. So the semen itself is alkaline. The urethra, the male urethra is acidic to kill bacteria. The vagina is very acidic. And so the alkaline semen will neutralize the acids in the urethra and in the vagina. The vagina is acidic. It's open to the outside, just like the urethra is. So we need to kill bacteria. So we have an acidic environment. And we need to neutralize that if the sperm have a chance of ultimately reaching the site of the egg, if there is an egg there. Other things that take place with semen. Semen contains prostaglandins. Prostaglandins are a type of hormone, if you remember. It does a couple things for us. It helps to break down the viscosity of the mucus plug so that the mucus plug isn't plugging the cervix. It also causes reverse peristalsis. See, because typically what will happen in the female at orgasm is that her uterine contractions are going to be pushing away from the uterus. Those uterine contractions during orgasm are going against the flow of semen and sperm. The semen tends to reverse that, so the contractions go up towards the uterus, up towards the uterine tube. Something else that semen has to do, it causes the sperm motility to increase. It provides ATP in the form of fructose. It has an immunosuppressant property against the female's immune system because the female's immune system will recognize those sperm cells as foreign. The antigens on the surface of the sperm cells are foreign to our foreign structures, and the immune response will be to attack them. And so they had to suppress that to some extent. The semen also has some antibiotic properties, and another function of the semen is to coagulate, to block to keep sperm and semen cells, sperm cells and semen from migrating back out of the uterus. They tend to form a plug, so that a clot, if you will, to try and retain as much of the semen and sperm inside the vagina as possible. So the semen is about somewhere around 7.2 to 7.6. It's slightly alkaline, not very alkaline, but slightly alkaline. It's not as acidic, because remember the inside of the vagina is acidic. So we're slightly alkaline to neutralize that. We know that semen is produced 60 to 65% in the seminal vesicles and 30 to 35% in the prostate and another 5 to 10% in the vulvourethral gland. And there's our ejaculatory duct. Okay. Prostate gland is going to make the other 30% or so. It has enzymes, it has citric acid, it may be slightly acidic, and it produces a protein known as prostate-specific antigen. Prostate cells produce prostate-specific antigen. And that is, those are the markers, if you will, on the semen. Those are biological markers. Now, the prostate-specific antigen is also a very important test for the possibility of prostate cancer. This is where the term PSA test comes from. PSA is prostate-specific antigen. Males can have blood test done to evaluate their PSA levels. And a rise in PSA levels may indicate that there are cancer cells growing in the prostate. Doesn't guarantee that it's prostate cancer. It's not a definitive test. It's an indicator. It's not 100% reliable that a low PSA means no cancer and a high PSA means cancer. The definitive test, the ultimate test to determine if anything's going on in the prostate, is a biopsy. So we'll talk more about that later on. Anyway, so the term PSA test, if you ever hear the term PSA, we're talking about prostate-specific antigen. The more prostate cells we have growing in the prostate, the higher the PSA numbers we get. So if we have cancer cells growing in the prostate, then we would see a higher PSA value, theoretically. It works pretty well as an indicator. It's not 100% reliable. Neither is the rectal exam 100% reliable. But those are two fairly good screening tools. Okay. The vulvourethral gland is at the base of the penis. It produces the last 5% or so of the semen. This is what comes out first. This is what neutralizes the acidity, the alkalinity in the urethra. It kills bacteria for us and helps to cleanse the tip of the glands itself. So now the ejaculatory duct and the vas deferens, the vas deferens comes together with the seminal vesicles to form the ejaculatory duct. The ejaculatory duct then merges with the urethra in the prostate. During ejaculation, we force the sperm and semen up from the testes. We force the semen out of the seminal vesicles through smooth muscle contractions and then out through the urethra. The term vasectomy is a birth control measure involved the cutting and ligation, in tying it off, of the vas deferens in the scrotum. This is a almost 100% effective way of birth control. Because it's sometimes they leak. It's very rare, but there's anecdotal evidence of, if you can imagine it happening, it'll happen. It has happened. So, okay. This is a vasectomy, usually done to males in an outpatient setting. The vas deferens can be palpated and isolated, and an incision can be made over top of them in the scrotum, and then they're cut, and then you have to tie them off. Now they can be surgically reattached with some amount of success, not much. And it's also possible, but very unusual, if the ligation lets go. And you would have to, it'd be an amazing occurrence for sperm cells to find their way through the cut tube into the other side that has is cut. But nothing's impossible. But still, a vasectomy is almost 100% reliable. See, what happens is that you palpate the top of the surface of the testes. You identify where the vas deferens is, make an incision there, lift the vas deferens out, cut it and tie it, and put a Band-Aid over it. And 20 minutes later, your patient goes home. And generally, you would recommend that they put cold packs on there to reduce the swelling. And my brother-in-law told me that the best thing is to use a big 5-pound bag of frozen peas, because frozen peas will contour themselves to the shape, where you're going to place it. Because you don't want to take a bag of ice, just throw that down, because it's not going to contour itself, or one of those blue freezer things for your cooler. But a bag of frozen peas will, they're ice cold, and they're going to contour to the shape. And he said it was very comfortable. So anyway, I just thought it was interesting. Okay. Problems with the prostate. Prostatitis is a bacterial inflammation of the prostate. It can happen. It can be both acute and chronic. It's painful. It requires antibiotics to treat. It can occur, through the urinary tract. It causes lower back pain. The genitalia hurt. There are white cells in the blood, in the urine. It can be both inflammatory or non-inflammatory. Your patient will present themselves with a lot of pain in their pelvis. It'll hurt to pee, and their testes hurt, and it's probably going to be prostatitis. So, a much more common occurrence in males is what's known as BPH, benign prostatic hyperplasia. The prostate enlarges. Most males over the age of 60 will likely develop this. This is not related to prostate cancer. What happens is the prostate starts to enlarge. Hyperplasia means increased cell growth. It's not a malignancy. The cells just get bigger. And what they do is they compress the urethra and make it more difficult to urinate. And so what will happen is the prostate enlarges, the bladder is more prone to infection, the bladder swells up because it's retaining more urine. This can lead to damage to the kidneys. The biggest complaint, however, is the prostate enlarges and compresses against the urethra so much that a male will have to get up with this, will have to get up 3 or 4 or 5 times during the night to go pee. And as they say, it's a very unsatisfying stream that they have this great urge to urinate, but only a little urine comes out because the urethra is blocked. And so this is a real problem here. The urethra can be bent out of shape too. Now, there are a variety of ways of treating this. Surgery is the old standby, where you actually go into the urethra and grind away a lot of the extra prostate gland that's compressing there. Simpler approaches is something like angioplasty, where you run a balloon up the urethra and inflate it, and that compresses the enlarged prostate tissue and opens up the urethra again. Microwave radiation applied to the prostate may cause it to shrink. Radiation from radio waves, or perhaps using proton beam therapy. There's a lot of different medications that also shrink the prostate too. Lots of males, this is probably the most common complaint that your male patients over 60 are going to have with regards to the prostate, is this enlarged prostate. So, and then we get to the big one, prostate cancer. This affects males at the rate of about 1 out of every 6. We see it as the most common cause of cancer death in males. Risk factors: obesity, high-fat diet, high levels of testosterone in here are all risk factors. There's a familial connection. If you are a male and you have a history of prostate cancer in males in your family, then you're at a higher risk, simply because the tumor suppressor gene that was protecting you from prostate cancer decided to fail. Doesn't mean that every male in your family line is going to get prostate cancer, but it means that you're at a greater risk simply because somebody had prostate cancer. Now, the thing about the treatments are very effective, and the survival rate is very, very high, well into the high 90% rate in here. There are some side effects. Males may have erectile dysfunction issues. Males may have loss of bladder control, particularly if the prostate is removed. And prostate cancer is one of those peculiar cancers. It can be a rapid grower. It can be a slow grower. Depending on your patient and the age of the patient, the term watchful waiting comes into play. Because again, the age of your patient, when you consider, if you have a patient that is 90 years old and has developed prostate cancer, and it's a very slow grower, you're going to think about your treatment options here, if any, because if it is, it just depends. How aggressive are you going to get with a 90-year-old patient? Well, it depends on how healthy your 90-year-old patient's going to be. Are you going to recommend surgery for a 90-year-old patient? Are you going to recommend chemotherapy? Or are you going to recommend radiation? Or are you just going to watch and wait, because this prostate cancer will likely kill him in 30 years. He's already 90 years old. So what do you do? And that's a serious question. But what if your patient's 40 years old? You would likely be a little more aggressive treating a 40-year-old than you would a 90-year-old. Just depends. So we watch, we look at the type of cancer, we do a biopsy to see what kind of prostate cancer it is. Is it a fast grower? Is it a slow grower? That's also going to dictate the course of treatment in here. There are a variety of ways to check for this. The PSA level may be raising a red flag, because if there's a prostate cancer growing in the prostate, it's going to cause an increase. Those cells are going to produce more prostate-specific antigen, and so the PSA levels may go up. But there's all sorts of false positives with PSA too. PSA may go up for a variety of reasons. PSA may be down for a variety of reasons. Your patient may have a digital rectal exam every year as part of their physical, and the doctor may detect a bump on the prostate. Now, is that bump something significant or is it not? The problem here also is that if the if the family physician detects a bump here, then your patient's still going to, and the PSA levels are normal, he's still going to recommend, or she's still going to recommend that your patient see a urologist. Because remember, your family physician in a family practice is going to do digital rectal exams maybe once a week, twice a week, whereas your urologist is going to do about 10 of them a day. And so they're trained to detect what, you may think you have a bump. The urologist will tell you, yes, there is a lump in there, and tells you what side of the prostate it's on. Again, that doesn't mean it's cancerous. All it means is there's a lump in there that shouldn't be there. The definitive test is always the biopsy, where they take samples of the tissue and examine them histologically. Okay. This is the digital rectal exam right here. Inserting a finger up in through the anus into the rectum. The wall of the rectum and the wall of the prostate are very close together. And so you can palpate the prostate and determine if there is something in there that shouldn't be there. And you have enough leeway to feel all the way around and feel for a lump. If there's a lump there, it'll be once you detect the lump, it'll say, oh, that seems very obvious that it's always there, or it's been there. So now, the problem about those exams is that this is how most males feel about it. Nobody likes to have someone's finger shoved up their butt, in a clinical setting. But this is where, this is what we're looking at. This is where you can see the very close proximity of the prostate and the rectum. It's very easy to do a digital exam. Again, it's not 100% definitive. It doesn't tell you there's a cancer there. It tells you that there's something there, or it tells you that there's nothing there. The PSA test may come back positive. The digital exam comes back negative. There's nothing there. So what do? You have them come back and do a PSA test a week or a month later. PSA tests can get screwed up by all sorts of things. The day before your patient comes in to have their PSA test, they went for a 50-mile bicycle ride, or they rode their lawnmower and cut 10 acres. Or they did some other strenuous activity. They rode their motorcycle for a 100-mile trip. All this kind of activity, or they went horseback riding, all this kind of activity will alter the PSA test. So it totally messes it up. So, because it's going to be really hard to be definitive on any of these exams unless you have biopsy results. Okay. Prostate cancer comes in 4 stages, just like all other cancers do. Stage 1 cancer means that the cancer is growing in one location and one location only. This also applies to breast cancer, liver, any other cancer. Stage 1, one location only. Stage 2, it's in multiple locations still within the organ. So a person could have stage 2 prostate cancer for years and have several lumps inside the prostate. Stage 3 means that the cancer has spread to tissues immediately adjacent to the organ. In this case, stage 3, it's spread to the seminal vesicles. And in stage 4, we see it has spread to the seminal vesicles and has spread to the bone. It might have spread into the colon. So stage 4 cancer while we hear people say stage 4 cancer for this or that, it isn't necessarily a death sentence because it just means that the cancer has spread to other locations. So you have to keep a very open mind on this. The consequences of, many surgeons like to, many urologists like to remove the prostate. The downside of that, of course, is if you remove the prostate, then you're may have incontinence issues because you're losing the sphincter there that controls release of the urine from the bladder to some extent. So depending on how well the prostate is removed. The other thing is the nerve net that controls well, there's the nerve net, the parasympathetic nerve net that controls erection runs across the top of the prostate and the urinary bladder. And it's often damaged during prostate removal. So many of your patients that have had their prostate removed or destroyed through radiation may also end up complaining about erectile dysfunction. So it happens. And this is the biopsy. Uses an ultrasound probe that goes up through the rectum and presses up against, through the anus, presses up against the back wall of the rectum and has a needle in there. And then they'll push the probe up against the wall, trigger the needle, it'll fire in through the wall into the prostate and take samples all the way around. A very definitive way, just like there's a similar needle biopsy that used in breast cancer. It is very definitive in detecting, taking out tissues. Okay. Cancer cells, as I've said, cancer cells are just ugly. If you look at the top of the slot of the picture here, you can see normal, healthy prostate gland cells. We see these are secretory cells designed to produce, 35% of the semen. The cells form, they generate their semen and they store it in the lumen of these glands, and here, just like the lumen of any other organ or structure. You can see they're all about the same size. The shape is fairly normal. We don't have, overwhelming numbers of cells in here. Down here, the glands are shaped funny. They're irregular. This is a gland down here. Compare that to the gland up on top. Look, there's many more cells here because cancer cells don't have any kind of contact inhibition. Cancer cells will grow on top of each other. They don't mind doing that. Healthy cells have contact inhibition. They don't like to be crowded. Plus we have glands, we have all, normal glands in the prostate look like this. They're all about the same size, mostly about the same shape. We don't have, here we have all these clusters of glands that just look, it's like a jumble, if you will. Prostate cancer. We don't know what the cause is. We don't know what the cause is for breast cancer. We know that the tumor suppressor gene for prostate cancer ends up failing, just like the tumor suppressor gene for breast cancer fails. And we'll have a long discussion on breast cancer in a week or so. There is no connection between BPH and prostate cancer. Lots of males get enlarged, many males over the age of 60 get enlarged prostates. Only 1 out of every 6 develop prostate cancer. It is, as we say here, the most common cause of death from cancer in men over the age of 75. So it's significant. Now you'll notice in the mortality rates and the incidence rates, the US is very high in incidence, but we have a very low mortality rate, usually survival rates well over 90%. We see this also applies in Sweden and Canada. We see that the incidence starting to drop in other countries. And again, why? We don't know. We just don't understand why it occurs like it does. You know, is there a connection between people exposed to industrial chemicals? You know, is it lifestyle? Is it familial connection? You know, of because genetic because you have a familial pattern, you know, from your father, your grandfather, your uncle, somebody like that that has prostate cancer. You know, are you genetically predisposed to it? Okay, enough about prostate cancer. And we'll talk a lot about its counterpart, breast cancer, as you know, like the number 2 killer of females. So, okay. Changing gears completely, spermatogenesis, the creation of sperm, takes place in the seminiferous tubules in the testes. It starts at puberty. So whenever puberty occurs, whatever age the male starts puberty, you know, 10 years old, 12 years old, you know, 14 years old, whenever puberty starts is when sperm production starts. The sperm cells start out as diploid cells, but very quickly become haploid cells. A diploid cell has 46 chromosomes, 23 pairs. A haploid cell only has 23 chromosomes. So we call it haploid because the sperm cell has to have half the number of chromosomes, just like the egg. The egg has to have half the number of chromosomes. The female egg will have 23 chromosomes. The male sperm will have 23 chromosomes. The sperm cell determines whether the fertilized egg will be male or female, because males carry both an X chromosome and a Y chromosome. Males are XY. X is the female sex chromosome, Y is the male sex chromosome. Males are XY. Females are X and X. They have nothing but X chromosomes. Sperm cells, when they're produced, half of them will carry an X chromosome, half of them will carry a Y chromosome. If a Y chromosome sperm cell fertilizes an egg, it will be male. If an X chromosome sperm cell fertilizes an egg, it will be female. So the sex of the baby is determined by what type of sperm cell that fertilizes it. This process of producing gametes, eggs and sperm, taking it from a diploid level where we have a complete, 23 pairs, 46 chromosomes, to a haploid level is called meiosis. The production of gametes, sex cells, is meiosis. I just said all this. Our somatic cells are all the cells except the sex cells. So all the cells in our bodies except the sperm cells and the egg cells are going to be somatic tissue, and they're all going to have 46 chromosomes. There's 2 pairs of chromosomes in every somatic cell. There's 23 sets, 23 pairs, 23 chromosomes from our mother, 23 chromosomes from our father. That gives us 46 chromosomes. That's a diploid set. The gametes only have 23 chromosomes. They're haploid. They only get half of the pair. So to get to the haploid number of 23, we have to go through meiosis. Now, remember in AP1, we talked about mitosis. Mitosis is nuclear replication, where we copy the DNA so we have a complete set of chromosomes so that the cell can go through mitosis and then cell division. Yeah, so we are replicating our chromosomes. So like if a skin cell is going to, when it gets old, it's going to undergo mitosis and cell division and give you 2 new daughter cells, you know, or a bone cell will do the same thing, you know, or an epithelial cell lining the gut will do the same thing. Well, that's great, except what we want here is not nuclear replication. We want nuclear reduction. We want to produce a haploid cell. Now, to get that, in meiosis, we have to go through not one one round of cell division, but 2. We go through meiosis 1 and meiosis 2, but we only copy the DNA once. So if you remember from mitosis, where we get to the S stage in the cell cycle and we replicate our DNA, we have a second set of DNA, and we very quickly then go into the stages of mitosis and then cell division. We get 2 daughter cells with brand new DNA. Well, now if we divided that again, we'd end up with essentially meiosis. So we can get 4 daughter cells. We want to get from diploid to haploid. The other neat thing that takes place with meiosis is that we sort of mix and match the various chromosomes so that we have diversity among the traits. This is why somebody can have, have you ever heard someone say to you, well, you look just like your great-grandfather, you know, or you have your great aunt Sarah's eyes, you know, or something like that. You know, Aunt Sarah has been dead for 100 years. She's not going to need your eyes. You can have them. You have sorry, that was a bad joke. You have picked up the genetic traits. You know, all those traits are being carried around in your family, your genetic, your gene pool, your family, and every now and then they pop up. Yeah.
That's how my brother is. Like, I look just like my parents. Fallon, my brother, doesn't really look like either of them, but he looks like people, like my mom's side of the family.
Yeah. The inherit, you know, you inherit these traits, and sometimes they pop up. Sometimes they show up in the offspring. You know, usually children look like their parents, but there are traits that can you know, because we're mixing these traits around a little bit, like hair color and eye color, body stature, you know, little things like shape of the nose, shape of the cheekbones, things like that. You know, you're not going to have like 4 arms or something like that, but you're going to get certain characteristics, and that's where we get the diversity in here, because the DNA gets sort of jumbled up a little bit. So this is what meiosis does. Meiosis gives us a little bit of genetic diversity. So spermatogenesis takes place in the seminiferous tubules. The first thing that happens here in the seminiferous tubule is that spermatogonia, the stem cells, and these are stem cells. These are the stem cells have the beauty of they will undergo mitosis, and then they can develop into other cells. So we have stem cells lining the inside layer of the seminiferous tubule. These spermatogonia undergo mitosis. Half of those spermatogonia stay there. So every time we have, you know, if we have a spermatogonia, a stem cell, it will undergo mitosis and give you 2 new daughter cells, identical to the original cell. One of the daughter cells will stay there. The other will start moving down the pathway to become produce sperm cells. So we start out with mitosis of spermatogonia, and the daughter cells are called spermatocytes. They're diploid. Half the spermatocytes stay right inside the lining. The other half become secondary spermatocytes and then become spermatids and then become sperm. So first thing that takes place, the stem cells will undergo mitosis and give you a type A daughter cell and a type B daughter cell. They're identical except one's type A and one's type B. The type A cells stay there. They stay right up against the inner lining of the seminiferous tubule. The type B cells start moving towards the lumen of the seminiferous tubule, and they become the primary spermatocytes. The type A cells stay there as spermatogonia. So type A stays, type B goes. Because if we didn't keep half of the daughter cells there as spermatogonia, how would we ever continue to produce sperm cells? We can't have everybody going off to become sperm. Half of them stay there so they can keep making new sperm cells. Okay. So the spermatocytes, the primary spermatocytes, which are diploid, undergo meiosis 1 and produce 2 haploid secondary spermatocytes. And those secondary spermatocytes undergo mitosis 2 and become spermatids. And the spermatids then will ultimately become sperm cells. So we have 2 stages of meiosis, meiosis 1 and meiosis 2. In meiosis 1, the diploid cell becomes 2 haploid cells. We replicate the DNA and we undergo meiosis 2, and we end up with 4 haploid cells. The spermatids that we formed have the right number of chromosomes, but they don't have any tail. They don't have any ability to move. So they continue the process of spermatogenesis, spermiogenesis, where the spermatid develops a tail and becomes a spermatozoan, which is the sperm cell. And if you're a visual, like a lot of us are, this is a real good approach here. There's our spermatogonia at the top, the diploid cell. It gives you a type A and a type B spermatogonium. The type A's stay there. The type B's become primary spermatocytes. They undergo meiosis 1 and become secondary spermatocytes. They replicate their DNA. They become spermatids. And then they start undergoing spermiogenesis and become spermatozoans. And at that point, now they have migrated into the lumen of the seminiferous tubule. The whole process of spermatogenesis takes about 72 days, a little over 2 months. The sperm cells can't swim until they develop, their tail is not motile until they're ready to be ejaculated. The fluid in the seminiferous tubule and ultimately in the epididymis are going to push the sperm cells. Essentially, you're pushing the sperm cells into the epididymis so they can develop their motility and build and develop their enzymes on the head of the sperm. Okay. So just a few points. We've talked about this in lab. The head of the sperm contains the nucleus. It is protected by a structure known as the acrosome, which holds the enzymes that allow it to penetrate the egg, because there's 2 layers that we have to burrow through to get into the egg. The midpiece is where the mitochondria is. The midpiece is located right behind the head. And that's where we're going to get our energy to power the tail. It's a flagella, and it will whip back and forth to push the sperm through the semen. And it looks like this. The acrosome is like a helmet that protects the head where the nucleus is located. All of your digestive enzymes are contained within the acrosome. They don't get released until they are in contact with the layers around the egg. There's the midpiece where the mitochondria are located, and they're going to generate energy from the fructose to power the flagella. Yeah, let me just wrap this up. The sustenticular cells that surround the spermatogonia, they are going to, I guess, sort of like Golgi, glial cells do to the nervous system. They're going to provide nutrients. They're going to protect the spermatogonia. They're going to provide fluid for the sperm to be transported into the epididymis. We have the sustenticular cells do something that's very, very important for us. They form a barrier, a tight junction barrier around the seminiferous tubules, because the sperm cells are not recognized by the male's immune system. Male's immune system, just like the female's immune system, was developed in the first year of life. Now, the T cells and the B cells that develop the immune system are exposed to all the different antigens, the glycocalyx structures on all the cells in our body. Now, T cells become what we call immunocompetent in the thymus gland, so they're exposed to all these different types of antigens. So they know to identify every cell in our bodies as us. Sperm cells don't start getting produced until puberty in the male. The T cells never saw sperm cells before, so they would recognize them as foreign. So the sustenticular cells form tight junctions around the blood supply so that T cells can't get out and attack sperm cells developing in the seminiferous tubules or in the epididymis. They would be considered, as far as the T cells are concerned, sperm cells are foreign because the antigens weren't there when the T cells were becoming immunocompetent, capable of recognizing our own antigens. And this is what those cells look like. Here's our wall of the seminiferous tubule. These are the sustenticular or Sertoli cells. Here we have this is a spermatogonia, a primary spermatocyte, a secondary spermatocyte, and spermatids here. Okay, and this is a great place to stop. And I will we'll pick up on this next Monday. And lab on Monday, we'll be looking at blood cells. So, and I'll see you all later.